means that if antibiotics cease working, then even very routine healthcare is at risk. So that is definitely the case. And of course, on the malicious side, whether the committee would have looked and considered many times on the risks from state or non-state actors on those, what type of attacks, either on purpose or even releases unintentionally. But I'll leave the malicious to one side. But I think pandemic flu, infectious disease from animal origin, and AMR. Thank you.
Professor. Professor Simpson, you're still mute.
So, sorry, Chair. I would agree with both the previous speakers. On natural occurring threats, pandemic influenza still would be the #1 threat, as it has happened 3 times in the previous century. AMR, antimicrobial resistance, is extremely important, and particularly transfer of diseases from animals across to humans, and animal disease is a particular threat at the moment.
Thank you. Could I just probe slightly more, but not at length, Sir Patrick, on one issue? I noticed all of you drew together an infectious disease pandemic, but in 2017, I think it was, the risks of pandemic influenza and of emerging infectious diseases were considered separately, and the infectious disease threat was thought to be perhaps less strong. Does that reflect a slight change in approach or understanding of recent years?
Well, the reason I would have it, and the way I expressed it, is I think pandemic flu remains the highest risk because flu virus mutates so readily and can make the species jump. Therefore, we just know from history that's a big risk. What we've now seen, of course, is coronavirus can make that leap in quite a dramatic way as well. So you'd have to say that actually a coronavirus outbreak with a mutation is possible, although this virus mutates much less easily and much less quickly than flu. And I think other jumps from animals to humans and other infectious diseases could come. So as a group, you might say, well, there's a possibility there that could be as high as pandemic flu, but for each individual one, it's got to be I suspect it's much less. And one of the problems is it's very difficult to predict. And actually, if you look at the history of the last 20 years or more, people have been, it's not been easy at all to predict what is the next infectious disease.
No, absolutely. That brings me on or back to the question of the National Security Risk Assessment. That process at the present time is led by the Civil Contingencies Secretariat. And I would like to ask each of you in turn how you'd characterize your organization's involvement in that risk assessment process. So you again first, if you don't mind, Sir Patrick.
So as you say, this is led by the Civil Contingencies Secretariat. The role of the Government Chief Scientific Advisor and the Government Office for Science is to comment on, help and probe methodology. So to look at the way in which it's done and to see whether there are ways in which there could be new science that could help that. The Chief Scientific Advisors across departments will look at the risks that are coming up through departments and try to be part of commenting, challenging and making sure that those have got the right external input. And then the aggregate across the group of chief scientific advisors and this office here, Government Office for Science, will look across and see whether we think we've got consistency and whether there are some things that we think may be missing or misplaced. But our role is one of advice and challenge, with the process being owned by the Civil Contingency Secretariat and by individual departments.
Thank you. Ms. Swinson.
Thank you. So yes, the Cabinet Office lead the cross-government process. The departments, so my department, DHSC, leads on our respective and relevant risks. which, as you know, is pandemic flu, the emerging infectious disease, and AMR, and also input on the cybersecurity risk and the provider failure, particularly on the adult social care. So it's our responsibility to update the risk assessments, both on the likelihood and impact, which we commission from PHE, which I'm sure Professor Simpson will go on to talk about, and then to submit those to the Cabinet Office and take any further questions or challenge from them. And they clearly look at the relative positioning of the risks that come across government. And then, of course, once that process is complete in any given cycle, we're responsible for the planning and responsiveness against those risks and the readiness of government.
Thank you. Professor Simpson.
Yes, our role is to protect and improve the nation's health. Amongst other things in this area, in this field, we track and monitor potential threats around the world. We develop new technologies to detect potential threats, both naturally occurring and due to deliberate release, and we conduct exercises and to test and improve to detect and improve the protocols. As has previously been said, we do develop risk assessments, and that process does include our veterinary colleagues to have a One Health approach to the threats. We support the cross-government biosecurity work. We input into the implementation of the strategy, and we have various mechanisms where we assist in delivery of response.
Okay, and just one more to you, Sir Patrick, and then I'll move on. We hear a lot in all this process of risk assessment and planning and so on. We keep hearing the phrase reasonable worst case scenario. What does that mean to you? And do you think it's been helpful in dealing with the present pandemic?
The reasonable worst case scenario is a process owned centrally by the Civil Contingencies Secretariat, and we input in this case from SAGE in terms of providing some of the modelling to go behind that. And it is an assessment of something that could happen, is not likely to happen, but would be the sort of worst case you think would be a reasonable thing to appear. And you know, therefore there's an element of subjectiveness in it, because inevitably it relies on certain assumptions, it relies on certain boundaries of what you think is reasonable and what you think is not reasonable. It's not the absolutely worst thing that could ever happen, and it's not the most likely thing that you think will happen. And it's somewhere between those two, bounded by an assessment of what seems reasonable. And that's where the subjectiveness comes in. So it has a utility for planning purposes, but I think, of course, it has very wide uncertainty around that. And one has to take that into account when thinking about planning.
Thank you. Baroness Lane Fox.
Thank you. I'm going to ask some questions about planning as well. Firstly, please, to Ms. Swinson. Hi there. You have specific responsibility, as you've already said, for the public health risks and supporting the response to the public health risks. In the 2018 Biological Security Strategy, you were already doing some work, I think, with the existing way you were organised. So two questions really. Firstly, what is the work you do beyond strategic? What's the response that you undertake, and has it changed after the 2018 strategic review?
Thank you. So I think you're asking about the biological security strategy, are you? Yes. So within that strategy that brought together the different biological risks facing government, I think two things that I would say. One is that the DHSC and other relevant departments kind of retain, of course, responsibility for those elements that are lead, so pandemic flu and global health security. At that point, there was also governance put in place for the things right across government, which is a Home Office lead, we're part of that overall governance board and a working group that's met, I think, 12 times since the report was published. So we take expert input in all of the areas we just talked about. And then in terms of the role of the Department of Health, you know, we are the leaders of the health and care system. We do some things, responsible for some things directly. So for example, preparing the legislation that was part of the PAN-flu work and which was helpful in preparing for the Coronavirus Act. We do other things which are coming together with our arm's length bodies, whether that's PHE or NHS England, for example, on working on surge plans. We're not you know, the operations for that is in NHS England and also, for example, in local resilience fora, but we work, so we're not operational as a department ourselves, if that was your question, but we work with colleagues in NHS England, local government, Public Health England and others on the things that the plans should be putting in place.
So did much change after the 2018 strategy?
So I would take that together with each review of the National Security Risk Assessment. It's on the basis of those reasonable worst case scenarios that, and there wasn't a major change in 2018. I think as Sir Patrick was saying, in terms of the reasonable worst case scenario, you know, both on the infection rate and on mortality rate, and now what we've seen for this actual pandemic, taking what we have seen from pandemic flu and the SARS and MERS outbreaks together, clearly, since our planning and this SAGE and Cabinet Office work on reasonable worst case scenario for this pandemic, that shows a much greater reasonable worst case scenario for the coronavirus than in the 2018 National Risk Assessment.
Thank you. And now to Professor Simpson, could you talk a bit about PHE's role in the same way, sort of moving from strategy to planning and how you respond?
PHE works with NHS England and with the Department of Health and Social Care to work with them to do the plans for particularly high consequence infectious disease. An example would be that after the Ebola in West Africa outbreak, we did a 2-year project with NHS England looking at how best we could improve the treatment facilities for people with high consequence infectious diseases, and that's been used in various outbreaks, such as the monkeypox outbreak, and for the building of respiratory treatment facilities for the early cases of COVID-19. We work with our colleagues working on the plans for biological threats, both malicious and naturally occurring, and also we design and deliver exercises for the Department of Health and Social Care to test the systems and to learn lessons based on the exercises.
Thank you. Finally, thank you, Sir Patrick. Could you answer the same point about how the Government Office for Science also moves from strategy to planning for the biological threats? And then also I'm interested in the natural hazard forward look. Even though I consider myself fairly good at Google, I found it very hard to find any information about this and the process. Perhaps you could talk a little bit about that group and what it does.
Yes, so the Government Office for Science provides advice in it, so we're not part of the planning process for this at all, and our input is part of what leads to any sort of strategy consideration. But we don't get involved in the operational side of this, and it's a relatively small office, so the operational side sits in departments and in agencies such as Public Health England. The natural hazard international natural hazard forward look is a way of bringing together the assessments that take place in a number of agencies. So the Animal and Plant Health Agency, Public Health England, British Geological Survey, and others, and bring them together in a format to be able to look globally at what the trends and risks are. And that then gets circulated to various parts of Whitehall in order to be able to get a map of the world and see what the changes are taking place. And that's brought together by the Government Office for Time.
So just one final question, does that work?
Well, it works in the sense that I think it is an aggregate of all of the detailed scans undertaken by the component agencies, and it's been pretty good at spotting where things are happening. But is it the perfect mechanism to bring it all together? I don't know. It relies very heavily on the detailed work that takes place in each of those agencies, which have all of the sort of scientific muscle and clout behind them to actually do the scans. And so that's the key input to that. The aggregation of that into a sort of single map is in a sense a rather easier part of the process.
Thank you.
Lord Harris.
Yes, could I follow that up? And I think the first question is really to Clara Swinson. We've been thinking about the biological security strategy, and this envisages a cross-departmental governance board which would oversee the shared commitments under that strategy. How exactly does that board work, and what is the department's role in this? And could you tell us, I don't know, how frequently the board has met and what have been the main outcomes of its work so far?
Yes. Of course, good afternoon. The governance board brings together Home Office, DEFRA and DHSC as the three departments for HMG who published that strategy, together with PHE, MOD, BASE, a range of other government departments. And it, I think, has met twice at that high level, senior civil servant level, since the publication of the strategy. There is a working group as well that's met much more frequently, and that work reports into the Security Minister, the Home Office lead, and from there on into the Cabinet Office as required. That's looking at the biological strategy overall. As that document sets out, that much of the work is within the department's existing governance strategies, governance mechanisms, and so that's the case, for example, on the Pandemic Flu Preparedness Board and the work that we've just been talking to on the National Risk Assessment work with Cabinet Office and other government departments.
Okay, I mean, you describe a fairly top-heavy governance board. My experience of those is that they don't always work very well, that attendance is poor. You've said it's met twice. Was it reasonably well attended?
So in terms of the range of departments that are required at that board and are on the membership, we'd have to check in with the Home Office, but I believe so. The working group, in terms of the work that reports and a progress update that I believe that is bringing together. Of course, with the onset of the pandemic, all of those departments are now working very hard on the response to the pandemic, and I would have thought that we would need to look at both progress against that strategy, its governance, and the progress against it when we are out of the acute phase of the pandemic.
Okay, thank you. Could I ask Sir Patrick, the biological security strategy specifically envisages that the government chief scientific advisor will maintain oversight of the strategy's outcomes. Now, somebody told me, and I have no idea whether this is accurate, that this was not something that you were consulted about before it appeared in the strategy. But could you tell us how you fulfilled that role?
Yeah, well, clearly the strategy was written before I joined and published after I joined, and so I certainly was not consulted about it, was not expected to be. And I think that strategy was put together from the Home Office, I believe, as the way to reduce that. And the role that we then clarified that was expected of the Government Chief Scientific Advisor is to look at the annual update report against progress and for us to comment on it. And that is what I'm expecting to happen as part of that.
Right, so it's a fairly hands-off role, your oversight.
As currently constructed, that is the role that's been described, which is that the annual review takes place. There's a report that's provided, and that then comes to me for comment and review. Okay,
and I mean, this is more general to all the witnesses, though I suppose primarily to Clara Swinson and Professor Simpson. With the experience of COVID, how could the biological security strategy be changed to improve the cross-government approach, and in particular the central to local government approach to biosecurity risks?
Thanks. Happy to take that first. So I think it's very much, as you've just talked about, the central governments coming together. I think on the central to local, those reasonable worst case scenarios that we talked about are provided to local resilience fora, and it's the responsibility of each government department working with the Ministry for Housing, Communities, Local Government to make sure that they have are provided with the reasonable worst case scenarios in order to plan against. I think with the experience of coronavirus, then clearly looking at the scope and extent of the biological threats that the UK faces would be something, you know, that, as well as the priorities for each department, whether that needs to go broader, the horizon scanning function, and then the types of things that need to be done, as you've already pointed to, between national, regional, local levels, according to those risks. All I would say is that any strategy or risk assessment, you know, and reasonable worst case scenario, none of those things are a prediction. And so responding to something, obviously you take the plans that you've got, they'll always need amending. And once we learn from this, which I'm sure we might come back to, you know, it's a problem for all kinds of crises that you end up preparing for the next one as if it was going to be the same as the current one. And we'll know, of course, and can prepare as far as possible for future threats, but we'll know that the next one won't be exactly like this one. So you need an element of flexibility in that.
Yeah, I understand that. I mean, could I just come back? I mean, we're going to move on to local resilience forums in more detail, but I can envisage a circumstance where this area of work generates a you know, a best worst case, you know, a worst case, reasonable worst case scenario, and so do all the other high risks. And these all arrive simultaneously or over the course of the working year at a local resilience forum. Does anybody say, actually, this is the one, or these are the ones you ought to be taking more seriously? Was any particular priority given to these?
Yes, you make a very good point. I think that's the role of the Cabinet Office, looking at all of the risks from departments, putting them in the risk assessment, thinking of which of those are then tiered into tier 1, 2 and 3, and they're responsible for then putting those out to local resilience fora with any guidance about which ones to focus on. As I'm sure we'll come on to, obviously in any given time frame and exercising programme, for example, on exercise sickness, pandemic flu, the Cabinet Office has decided, you know, according to priority, to work on other major risks such as national blackout or flooding, depending, and then therefore they get a particular focus in that given year.
I don't know whether Professor Simpson or Sir Patrick, for that matter, Professor Simpson wants to comment.
Yes, thank you. From Public Health England's standpoint, we do have obviously we have local health protection teams who deal with actually the actual hands-on control of infectious disease. And an important part of our work nationally is to get what the Cabinet Office's and the CCS's priorities are to those local teams, and to produce plans and to exercise on those priorities, which may be biological, but may well be non-biological threats such as cyber threats or threats to or threats such as power outages. So that's the way we work, and I think from COVID-19, this is a part of our activity that will need to be strengthened.
Okay, I don't know if Sir Patrick wants to add anything.
Well, maybe the only thing to say is that when we think about the assessment of likelihood and impact, it's that methodology of how to get that right, which becomes very important in terms of then the prioritization of these things. And that is particularly difficult when you are trying to compare chronic risks with episodic risks. And I think that is an area that we're looking quite carefully to say, well, how could you get that to be in a way that will then be meaningful as you translate that into priorities?
Lord
Okay,
King, I think Lord King, you considered coming in on this.
Yes,
Do you still want to?
particularly for Sir Patrick. In your oversight of the outcomes of this strategy, you're doing that. Who do you report to?
The job that, in terms of commenting on this, then goes into the Civil Contingencies Secretariat, and the document that's signed off finally by the National Security Committee.
But who do you actually report to?
Oh, I report to the Cabinet Secretary.
To the Cabinet Secretary?
Yes.
And then how many different Cabinet Secretaries actually haven't had the same turnover? Who is he reporting to? Does he report to the Prime Minister?
The Prime Minister.
Yeah, because it's one of the problems about who's actually taking responsibility at senior level and ministerial level. And the amount of changes that have been seem to me to have people who actually have some understanding of the area of responsibilities they have is a major problem at the present time. Do you agree?
Well, I think in any organisation, turnover can be an issue in terms of institutional memory and other expertise.
But you found that the Cabinet Office understood the strategy, knew where it had come from, and knew what its objectives were.
I think the Civil Contingency Secretariat has had very strong, consistent leadership, and I mean, it's respond to, but sorry?
Who's the leadership of the Civil Contingency Secretariat?
Well, so Catherine Hammond was leading it until very recently. She has moved on now, but for the entire time I've been in post, she was the person who was leading this.
Right. Thank you.
Thank you. Baroness Hodgson.
Thank you very much. So my questions revolve around scientific expertise during emergencies and the SAGE system. And particularly to Sir Patrick, the SAGE mechanism is vital for ensuring that scientific expertise underpins decision-making during emergencies. But how do the SAGE activations work? And in your view, what are the strengths and weaknesses of this model for getting scientific input when monitoring and dealing with significant public health risks? And in particular, what happens when there are diverse viewpoints, as we read in the papers, have happened from time to over this pandemic? And how do you reconcile the views of different scientists to come forward with recommendations, solid, clear recommendations for policymakers' decisions?
Okay, lots of questions there, and I will do my best to answer them all. So the process of activating SAGE is that it is called by COBRA. So when COBRA is called, they can call SAGE for an issue which is complex, cross-government, and requires scientific advice. Separately, there's something called a precautionary SAGE, which I can trigger if I wish to try and get ahead of things and to try to anticipate that SAGE would be called. But formally, it's a COBRA decision to call SAGE. The Government Office for Science then assembles the experts that we need for any particular emergency. And in my time, in the 2.5 years I've been here, that's included Novichok, it's included Toddbrook Reservoir, it's included a precautionary SAGE on Ebola, and of course a lot on COVID. The office will go out to government departments where there are experts on scientific advisory committees. They're usually external people from government who are known to be on scientific advisory committees. We will ask the learned academies for experts. We have our own expert lists, and we will ask specialist bodies, and we'll bring together a range of experts for the problem we have in front of us. That doesn't mean that those individuals would be on SAGE for the entire duration of whatever the problem is that we're trying to address. You asked a specific question about public health, and in matters of public health, SAGE is co-chaired between the government chief scientific advisor and the chief medical officer, as it has been during this outbreak for very obvious reasons. And the CMO has ultimate accountability for public health matters. That then brings in a whole other raft of experts who can be part of this. Inevitably, and this is exactly what you'd expect for and hope when you brought together a group of diverse scientists, it would be very surprising if everybody thought exactly the same thing. We have subgroups which feed into SAGE, and on this particular emergency, we've got many subgroups that feed into SAGE. So we've got at least 100 people who are working on this, usually nearly all outside academics, but also, of course, the chief scientific advisors from departments who are outside academics who've come into government for a short period. And those bodies will feed in information as well, and they will have their own consensus process to try and come up with consensus input into SAGE. SAGE is a process of then trying to come up with a view with the uncertainties expressed. And it's very clear that science is very seldom a complete utter fact that is immutable and something that's never going to change. Normally, science is the best representation of what you can know today, but accept that as more evidence accumulates, you will, of course, need to change. And it's a position of trying to the uncertainties around the evidence that you have today. So that's the way that SAGE works. And I will say maybe one final thing, then ask you whether I've answered your question. We've also worked a lot with international bodies and other science advisors in other countries, many of whom have been across to look at the SAGE mechanism, because it is unusual. It doesn't take place in all other countries. Some have got the model a bit like it, not many. And over the past 18 months or so, we've done mock exercises with Canada and the US where they've been to look at the SAGE model, and we've done mock exercises where we've had a similar problem that they've tackled through their process, we've tackled through our process, and we try to learn from each other.
Thank you. I think you've covered most of that. Could I just ask one other thing, that how would SAGE cope if there were multiple emergencies at once?
Yes, well, maybe I may answer that in two ways. But actually, the first thing to say is, how does SAGE cope with an emergency that's gone on for 62 meetings, which is where we are at the moment? Mm. That itself brings a challenge, because it wasn't designed to work for that length of period, and it does put strain on the academics and others who contribute to this. And we've taken a lot of trouble to try and make sure that they are as protected as possible in their own institutions to be able to contribute. And I would like to, on the record here, say how brilliantly they have performed and how much they've given up almost all of their other life, both professional and often personal, in order to work on the problems that we've been tackling during this COVID crisis. But resilience of long-term application to SAGE is a big issue that I think we need to formalise going forward, and indeed for the team looking after them in the Government Office for Science. one of the things that we've done over the summer is exactly what you're getting at, which is concurrent emergencies. And we've now got a separate team set up in the Government Office for Science looking at concurrent emergencies. I've been receiving briefings on some of the updates on other areas that we would be concerned about in emergencies, and we are set up to run a parallel process should that be required. It won't be easy though.
Thank you very much. I think my colleague Baroness Neville-Jones wanted to come in here.
Thank you. So Patrick, you rather presciently got onto the subject that I wanted to ask you about. You said in answer to Baroness Hodgson right at the beginning, you said COBRA calls SAGE into action when cross-government advice, the cross-government activity is required, and it requires scientific advice. I mean, COBRA is a short-term emergency body, not really designed to mastermind, a long-term activity of the kind that COVID has clearly become. Now, you've talked about the effect on SAGE itself. What is your view about the actual machinery of government, though, in relation to the advice that SAGE is giving? What one doesn't hear is mention of the National Security Council itself. So what's been your experience as you've gone on? To whom and in which bodies do you find yourself reporting? I mean, are you asked, for example, to attend the National Security Council? Or what relationship do you have with decision-making bodies?
Yeah. In answer to the question about the National Security Council, yes, I attend the National Security Council on this and other matters. And there have been obviously several sessions which have discussed COVID, but the government has established Cabinet Office has established a structure for dealing with COVID with a central team based in Cabinet Office and ministerial committees that take accountability. Plus, of course, there are lead departments, the most central of which is obviously DHSC. So the output from SAGE goes to all departments. It goes to the Cabinet Office COVID task force and will feed into the ministerial committees. It will also go obviously to DHSC. It's worth saying, of course, there are other forms of scientific advice that feed in through departments, and each of the chief scientific advisors in the departments will listen to SAGE and take their own information back to departments, and many of them will have their own advisory boards feeding into specific questions in departments, much more operational than SAGE would be, and DHSC has its own forms of scientific advice to feed in as well. But that's the route, rather than what would happen in a shorter term emergency, whereas our output would be SAGE to Civil Contingencies Secretariat and COBRA. It's a slightly more complicated picture now, but our key recipients would be the Cabinet Office COVID task force.
Well, that's very interesting. Thank you. It seems to me, I don't know what view you take, that some of these emergencies that we're going to face in the future are going to be of longer duration and requiring extensive follow-up to the initial event. Do you think what you've just described is something of a model that will be replicated, possibly involving different departments, but of a kind which we will now need to go for when we're dealing with longer term situations where the society has to live with whatever is afflicting it for a period of time?
Well, I think the model of requiring central coordination and a team to run it, where it runs across department, is obviously one that makes sense from an operational perspective. And I think that as things become more chronic problems, it's rather important that departments pick up the running of that. And so, DHSC has done a lot, and that's part of why organizations like the Joint Biosecurity Centre have come into play, because there needs to be a more long-term stable system with internal government science providing advice into it, plus getting its own external input, rather than thinking that you can run this from SAGE for the whole time, because SAGE is an advisory body built up from external academics largely. It's not part of the government operational machinery, and certainly can't be something that runs for very long periods.
So the government departments have to take it as part of their normal operations, in effect, yes. So in the end, your role at some point will come to an end. I mean, other than from time to time offering advice.
Yes, I mean, I think that's, if you take a short-term emergency, that's exactly what happens. Cobra calls Sage, Sage meets for the duration of the emergency, Cobra stands down, Sage stands down, and in a way, something similar at some point will happen here.
Thank you very much.
Lord Pole, and I
Thank you.
apologise, I gather I didn't see your hand before. I'm sorry about that.
That's all right. Well, Sir Patrick, just continuing on the questions of Sage, some of our earlier witnesses have suggested that it's not a diverse enough body. Now, I'm quite simple-minded. I would expect a scientific advisory committee to be full of scientists, but apparently they think there should be other sorts of skills represented there, more operational skills, people who know about supply chains and that sort of thing. Do you think there's any validity in that criticism, or are you happy to see non-scientific issues left entirely to non-scientific bodies?
Well, I'm quite a believer in getting experts to run what they know about. And Sage is science advice for government emergencies. It's not the advice how to operationalize things. It's not the advice on economics. It's not the advice on all sorts of policy matters. And I think it's rather important that it isn't. Our role is to provide, to the best of our ability, scientific input into decision-making and advice. That needs to be integrated by ministers and others, taking into account many other forms of evidence and advice. And I really think it would be a mistake to try and integrate all of that into a single body, not least because the output then becomes something which sounds like a ministerial decision, which is something that Sage simply can, in my opinion, can't and shouldn't do.
I think that's absolutely right. On the other hand, there is an impression that Sage has been asked questions which are not strictly within its ambit for advice on wider issues. Do you think it has been misused at all in that sense? But perhaps slightly more impertinently, do you think politicians have taken to hiding behind Sage in order to thrust Sage forward as to be apparently responsible for the decisions they don't themselves want to take or be associated with?
Well, if we get questions which may come from departments or come from centrally that we think are not science questions, we tell people they're not science questions, and we stick to giving the scientific advice. The scientific advice, of course, can be interpreted as a policy position, which it's not. I mean, it can be turned into a policy position, but that's for somebody else to do. And we stick with giving advice. And one of the things which I think has been important in this pandemic has been the Sage advice has been very visible, has been open. We publish all of our papers and our minutes, and it's there for everyone to see. And therefore, it attracts a lot of attention as being somehow the advice. It's not the advice, it's simply the science advice. And the science advice needs to be incorporated and with all the other advice that ministers rightly will need in order to make decisions. And some of that is obviously less visible than Sage. So I think part of the reason that Sage has been quite so prominent in terms of the way people think about this is the visibility of the advice that we give in comparison with perhaps where other advice comes from.
So you don't think in any way Sage has been misused by ministers, not in a malicious sense, but simply as an excuse sometimes?
Well, you're straying, Lord Pole, way outside my area of expertise on how politicians might behave in this circumstance.
I'm a great believer in straying outside those limits.
Lord Harris, I think you wanted to come in at this point.
Sorry, I suspect Sir Patrick will think I'm straying too far as well, but it's sometimes been said to me that yourself and the Chief Medical Officer have appeared like a human shield around ministers. Is that something you recognise or have ever felt?
Well, I'm sorry, and I didn't mean to accuse Lord Pole of straying. I mean, I was in danger of straying beyond my expertise. I think that if I answer the question a slightly different way, have I felt uncomfortable at times during this? Of course I have. It's been, it's been a position of visibility which I wouldn't seek, and it's a position of visibility which I do not enjoy from that side. But I don't think that we've done anything other than try to present the science as we see it in the fairest way, with the uncertainty clear. How others choose to interpret that and use that is a different matter. And I don't feel that we've been used as in any way as shields. I don't think that's the tenor of the discussions that I've had inside government.
Thank you very much.
Sorry, Mr. McNeil, you want to come in on this point?
Yeah, indeed. Thank you very much. It basically is on the sort of the groupthink idea that's in that could be in SAGE, and how much sort of learning are you doing from colleagues across Europe? It's obviously a difficult question, but there's one in particular that stands out, and have banished COVID 3 times in the Faroe Islands. And I'm just wondering how much you might have learned from places like that in regards to level of testing and searching for asymptomatics as well. And maybe, given they've banished COVID from the territory 3 times, is there anything that you can transfer over?
Yes. Well, we speak, but when I say we, that's both me and the Chief Medical Officer speak a lot to our colleagues around the world, not just in Europe, but around the world. I have regular calls with Canada, New Zealand, Singapore, South Korea, Japan, and many European countries. And we're all learning from each other. I haven't spoken to the Faroe Islands, so that's one that I haven't, but we have spoken to a lot of different places. It's perhaps not surprising, but it's always somewhat amazing when you hear that we're all struggling with exactly the same issues, of course. And I think we're all keen to make sure that we don't go down one particular path blindly. Chris Whitty is also very linked into the WHO, so gets a lot of input from there as well. And the groupthink issue is a really important one. On SAGE, we do have a range of different members. We do refresh the participation from time to time, and we did appoint somebody a few months ago now to observe us, somebody who was experienced, to make sure that we don't get into groupthink, or if we do, he can point it out to us. So we do our best to do it. And with over 100 people in different subgroups, and each of those having groups behind them in institutions around the UK, we certainly pull from a very wide range of science. And we were very keen and very pleased when the Royal Society set up bodies to do some of the same things. So we get the sort of, if you like, an independent view on this. So I think that, thing, but I mean, it's one of those things you don't know until.
Of course. I mean, it would just seem to, they found that 80% of those who are positive are asymptomatic, and they keep searching out the asymptomatics. I mean, the problem we have, certainly in Scotland and the wider UK, is not wanting to test anybody unless they're showing symptoms, which leaves 80% of those carriers unbothered by the entire process. But also their levels of testing in population are over 200%. I mean, having banished COVID 3 times from the territory, I would suggest that probably it's a search for the asymptomatics, those levels of testing that have probably done it for them. And it's our problem that we just don't have the capacity to test at that level, and therefore we are stuck with the situation of just only really searching out the people who say they've got symptoms.
Well, okay. First thing is just a sort of tangential point, but important, which is the notion of eliminating COVID from anywhere, as you've just described, is not right, because it'll come back. And so
it's come from other territories that haven't tested as well.
Elimination strategies and so on. I think that's very unlikely.
Although you could, if every territory was doing the same thing, you would imagine that then everybody could banish it. But if one territory is doing it and the other 199 aren't doing it, basically, was in the world, you've got a difficulty.
And I mean, it's worth reflecting that there's only one human disease that's been truly eradicated, and that's with a highly effective vaccine, smallpox. So it's a very difficult thing to do. In terms of testing, you're absolutely right. There's a high proportion of asymptomatics. It is a little unclear still exactly what that proportion is. It may be something around 60% or so overall, but I think there's quite wide uncertainty around estimates of exactly how many people really are asymptomatic. Would I like to be able to test far more, or do I think the UK would be in a better position if it could test far more? Yes, because we know that the only way you pick up a lot of people is through testing, and the testing then needs to be linked to action of isolation. So it's no good just to test, you need to do something at the end of it in terms of isolation. And the more you can get out there and test across asymptomatics as well, particularly in areas like care homes, in hospital settings and so on. And I think this is a strategy which the DHSC has laid out for testing, the better. And at the moment, and Clara could speak to this more than I can, but at the moment, the testing capacity is such that I think the UK is testing more than any other country in Europe, but it's nowhere near enough to do what you've just described yet.
On a final small point, the test will work just as well on people who are symptomatic and asymptomatic, because the test is looking for the virus, and therefore it doesn't matter whether the patient is showing the symptom or not. Or is that right or wrong?
Well, it's almost right in the sense that you're absolutely right. The test is picking up the virus, and therefore anyone who's shedding the virus will test positive. The only area where it might be a bit more difficult is if you're asymptomatic, you may get a less good swab, because you may have less material. Yeah. So occasionally you'll find people who are asymptomatic who may have there may be a slightly lower sensitivity, but the test will pick up both asymptomatic and symptomatic.
Thank you.
Mr. Jones.
Thank you, Chair. Just a quick supplemental for Sir Patrick, and then my questions are primarily about Public Health England, so I'll come to Professor Simpson after that. So Patrick, you just said that the only example of something that's been eradicated was smallpox with a highly effective vaccine. Just to push a little further on that, does that mean that in our deliberations in this inquiry, we need to envisage, even with a vaccine that we don't yet know how successful it's going to be for COVID, that this is something we're going to need to manage year on, year out in the same way as influenza, for example?
I think that's quite likely. Now, of course, we can't be certain, but I think it's unlikely that we will end up with a truly sterilizing vaccine, i.e. something that completely stops infection. And it's likely that this disease will circulate and be endemic, would be my best assessment. And I think that's the view of many people on stage, that that's a likely outcome. Clearly, as management becomes better, as you get vaccination, which would decrease the chance of infection and the severity of disease, or whatever the profile of the vaccines are, this then starts to look more like annual flu than anything else, and that may be the direction we end up going in.
Thank you for that. And so to Professor Simpson, in that context, I mean, we're all conscious that the Health Secretary was very critical of Public Health England and has since made the decision to instigate the National Institute for Health Protection as its successor body. And one of those criticisms from the Health Secretary was that PHE didn't have a permanent standing capacity to respond to these issues, or to scale up quick enough to respond to these issues. Given we've already heard today that similar but non-COVID related threats are still the highest priority threat for us in the context that we're discussing today, could you just help us understand whether PHE had that mandate in the past to provide a standing capacity to respond? And if it did, whether it was given sufficient resources, in your view, to do so?
Thank you very much. There is quite a lot to be said for the principle of bringing together Test and Trace, the Joint Biosecurity Centre, and PHE's health protection functions under one roof. And we're already beginning to collaborate very closely on this. It was from Public Health England's mandate was to protect the health of the public, and one part of that was to develop technologies such as testing to novel pathogens. It wasn't an explicit part of the mandate that Public Health England could massively increase the ability to do that on a very large scale. And that is one of the things and one of the lessons learned from the COVID-19 situation, which can be dealt with as part of the new organisation and part of its remit. But perhaps my colleague Clara Swinson may wish to come in from a DHSC perspective.
Clara, please feel free to do so. I mean, if PHE's job was to kind of consider the risks and build a model for responding, but then was not able to scale up in order to respond when it actually happened, was that the department's role to respond? Whose role was it?
I'm happy to come in. Going back to where we started on the reasonable worst case scenario, in terms of what each agency, whether that's central government departments or not, was planning to do, I think the scale of what has happened on coronavirus, given the asymptomatic spread and the differences from an influenza pandemic, meant that, when this started, there wasn't a test. So first it was a new virus, had to develop a test, then had to scale up. Now, getting to that scale, now, 300,000 a day, we've got the technical expertise to create those tests. We didn't have, as some countries, for example, Germany, had a very large private diagnostic sector that could be put to that. So we've had to increase the volume of testing, and ministers decided to set that up under NHS Test and Trace. That does use a lot of PHE capability, and as the Secretary of State set out in August, our aim for this winter is to focus on responding to the next wave of coronavirus, and ministers decided that an agency that had a single focus on health protection was designed to look at all biosecurity and other threats to health, was a change that they wanted to make, so that the health improvement parts of Public Health England will, that final decisions on the design of that will need to be taken, but will not be part of the same agency that's looking at those direct health threats. I'm happy to pick up any of your questions that I haven't reminded me.
Thank you. So prior to the institution, the National Institute for Health Protection idea, it was the department's responsibility to be able to scale up to meet these responses, these problems, not PHE's. Have I understood that right?
Well, the department and the agency in statutory terms are the same thing. They both report to Secretary of State for Health as an agency. So looking at the capability in the public health system and looking in the NHS, what tests could be done within public health laboratories, what testing could be scaled up elsewhere. I'd say we worked on that together, and Prime Minister decided to set up NHS Test and Trace in order to do that from May, I think it was, this year.
I'm just trying to understand why the Health Secretary was critical specifically of Public Health England, if, based on Professor Simpson's answer just now, Public Health England never had the capacity to scale up to meet this type of problem, which had already been anticipated in previous national security strategies. So is it not unfair to have blamed PHE for this if they didn't have the capacity to scale up in the first place?
Yeah, so I think going back to what the Health Secretary said in August when he announced the creation of the National Institute, there were various things that he praised Public Health England for, given the scale of what pandemic and testing. That's one of the reasons that he took the decision to set up health protection on its own. I don't think, just going back over time, I don't think there was any agency that would have had the scale to have 500,000 tests a day that could just have capacity that could be turned on. But clearly in the design of that new agency, and others will be doing it around the world, given what we have faced, thinking about the amount of capacity a country is happy to pay for to have spare at some points, and what you can turn on and off, or how you can turn capacity doing other things into this is going to have to be a part of what we've learned from this, and decisions will need to be taken on how much capacity to have kind of ready to go at any time and how much you can switch on.
Thank you for that. I mean, some countries did appear to be better prepared to respond quickly. Certainly that was the view of the Science and Technology Committee that looked at this issue fairly early on in the pandemic. And my last question back to Professor Simpson is that the government often refers to the Robert Koch Institute in Germany as the model it wants to adopt for the National Institute for Health Protection. But that institute in Germany relies on a very decentralized system where regional and local authorities have the budget, the people and the capacity to deal with these issues. Do you have any concerns about us taking that approach if we're not giving sufficient support or capacity to presumably local authorities in our circumstances to do this work as opposed to a national system?
Thank you. As you say, the RKI and the German health system is a different system to the health system we have in the UK. I think I wouldn't agree with you. I think the policy that the government is following to be able to increase rapidly the ability to respond to these sorts of threats it does seem to be a correct one. As you say, the German system is very different to the UK's, and therefore it's very difficult to transfer internationally one model which is based on one set of arrangements to another one, but a robust system whereby responses can be escalated is definitely a lesson that's been learned from this situation.
Just to push you very briefly, and then I'll hand back to the chair. Are you therefore suggesting that it's the right approach to invest in a centralized system to deal with these, or is your view that a capacity in a decentralized model is the better approach?
I think what I'm probably saying is it is best to invest in whatever the appropriate system for the way a jurisdiction is organised.
I'm asking you, Professor Simpson, in your expert view, which you have a preference for. Is it centralised or decentralised, or do you not have a view?
I don't have a view on that.
You don't have a view. Okay, I'll hand back to the chair. Thank you.
Baroness Neville-Jones, did you want to come in on this, or has your point been dealt with?
There is obviously a big difference between systems which are centralized and decentralized, and it does seem to me that this is now quite a big issue in the management of COVID going forward. If you don't personally have a view, could you characterize the nature of the debate in the department about the management of or the extent to which the system should be decentralized? Don't know which of our witnesses might like to take that. Perhaps Ms. Swinson.
Thank you. Yes, I'm happy to. So, I mean, I think the question about what's centralised and what localised is a question of balance. I don't think that there's, any system is going to need a balance between the two. Certain things work when you've got big economies of scale, whether that's call centres, some of the contact tracing, but on the other hand, some things work much better or requires local knowledge, and contact tracing requires that. So NHS Test and Trace is working with local authorities and testing teams in local authorities, which I think is now up in the 90s of local authorities who have those teams. Seeking the right balance between those two things, people debate and will have different views on that, but getting the right balance is what we're aiming to do, so that you can do the things at scale and the things locally. The only other thing I'd add is clearly, as a number of people have mentioned already, that debate people have different views on for public health, but also has to fit into the system of government. So of course, some other countries we look at do have a very different state or federal system. We've got one that needs to work through our local authorities. And of course, the debate about what the right balance is has to take account of that, or indeed have a review the situation and change that balance, but we've got to start with the system we've got between central and local government. Thank you.
It is, of course, the case.
Oh, sorry, Pauline, carry on. Okay.
I just want to say it is the case that the hospital system in this country is fairly decentralized with the different trusts. It's not entirely centralized system. I mean, do you foresee the local element getting bigger, or and greater responsibility being taken locally for things like test and trace in the future?
Thank you. Yes, you're quite right. I didn't mean to imply that our system was a centralised one, just that the balance between those and the balance in local government and NHS and other bits of public services differ. I think given the scale on testing that we need to, that's already being, has already multiplied many times and may continue to do so, I think that's going to need to be to a certain extent localized just because of the capacity. There's also the central labs which PHE run, labs in hospitals, private sector. It's going to need to be not something that is centralized but takes advantage of, already does take advantage of the laboratory capacity and the contact tracing wherever it currently sits.
Well, thank you. You're quite right. The laboratory capacity has also to be able to respond to greater localization. Chairman, thank you very much.
Baroness Healy.
Thank you, Chair. Ms. Swinson, you talk about capabilities and the need to be flexible, but you've got a terribly difficult task. And when making proposals to the Treasury in advance of the spending review, how does the department balance resources for its ongoing responsibilities with the resources it requires for contingency planning capabilities? And what lessons are you going to have to learn for needing so much greater resource than could ever have been envisaged before this pandemic hit the country?
Thank you. Good afternoon. You're quite right that given the costs of the pandemic in a huge number of ways, the amount of resources that we as a country put into our testing system, our health systems, for example, surge capacity, the Nightingale hospitals we haven't yet mentioned, but in the NHS, is a balance that isn't just on spare capacity that we mentioned on testing, but on a range of things. I mean, ultimately, these are political decisions that need to be made. As civil servants will advise our ministers about the extent of capability that can be increased scale, and those we'll advise on the health consequences. Of course, the economic and the social ones, ministers and cabinet and the Prime Minister ultimately, and the Chancellor will need to take decisions on.
I mean, may I ask, do you fear that other elements of the health service are suffering too much without getting the resources they need? I do hear surgeons talking about, they haven't got the resources that they want to do all the operations that have built up backlog.
Yes, so I think the Chief Medical Officer has talked about this right from the beginning. There's the direct consequences of COVID in health, and there's the indirect health consequences for other things that may not get the same resources. And then, of course, there are the health consequences from economic, social, other factors. Definitely, one of the things from the first wave going into this autumn that the NHS is seeking to do is to keep non-COVID health services running as far as possible. There were a number of services that had to be paused in order to be ready in the spring. I think the NHS has learned a lot about that, so that hopefully more of those can be kept on. We also know actually that sadly the public, even when some services or many services were kept on, the public didn't always seek them, and so a very strong message that you would have heard from Simon Stevens, from politicians and others, that the NHS is open for business across all of its health services. Clearly in the areas currently under greater strain, in the Northwest, for example, mutual aid across areas, both for coronavirus capacity, but also thinking how other services can be kept running is a really important operational issue for NHS England to be on top of, and in other parts of the UK, for precisely the reasons you point to.
Thank you.
Maris Hodgson, were you signaling to come in on this?
I was signaling to come in on the point before, actually, about testing. Do you want to take me at the end if there's time? I wanted to simply ask quickly about, we've had a lot of attention on, obviously, testing and tracing. And why have we abandoned testing on antibodies? It seems there's no public testing of antibodies, and therefore we have no information on how many people have had COVID. It would be good for people to know that they have had COVID, they did have antibodies, therefore they were perhaps not so much as risk. But also it's the mental health aspect. For people living on their own, the only publicity they see is gloom and doom and death. And many people are really suffering acute anxiety. And it would really be hugely helpful to have more information on recovery rates from COVID, rather than just the very negative press that's being shown right now. And I think it would help many people if they realised that not everybody ended up on ventilators in intensive care.
That is certainly the case on the numbers of cases and the numbers that then translate into hospital admissions and intensive care. On antibodies, I may have to ask Sir Patrick for the proper scientific view, but as I understand it, the sensitivity of those tests compared to those for whether you've got the virus currently is much harder to be confident on, which means that in terms of what tests are available, we need to make sure that they're effective, and indeed that when someone gets the result, that there's something that they can do with it. So there are lots of unknowns on the science for antibodies, immunity, how long it lasts, and so on. So that's a big area of scientific investigation and debate, not just in the UK, but globally. And in terms of the number of people, there are various sample studies as well, the ONS and others, and internationally, which I think also speak to your point about how many people have actually had the virus, what that translates to in terms of cases, and how many people in the population have had it in either asymptomatic or a mild version, which I agree with.
Would it be helpful for me to make a few comments on that?
Please do.
What we now see is that the vast majority of people who catch COVID asymptomatically or symptomatically get an antibody. So we know the antibody response occurs in most people. We know that some of those antibodies are what are called neutralizing antibodies. They are antibodies that will bind the virus and stop it being able to enter cells. And it looks like those neutralizing antibodies, as you would expect, do confer some degree of protection. So all of that is good news. Not everybody gets the same antibody profile, so people get slightly different antibody profiles. We also know that antibodies can wane after a few months, so we see antibody levels decreasing in some people, and we also know that some people can get reinfected. So although there's a lot going on with antibody studies, particularly to find out on a survey level how many people have had the infection, where those people are located. So we know, for example, that in London, in the first wave, it was probably something like 17% or so of the population were infected, whereas in most other parts of the country, it was quite a lot less than that. Overall in the country, from antibody studies, you'd say about 6% of the population got infected. It's much less predictive for you as an individual as to whether you are now protected against it and for how long. We don't know for how long, and we don't know the degree of protection. And so antibody tests, if you like, are clinically a bit less useful at the moment, but they're very important in terms of trying to understand numbers of infections, and to understand increasingly whether this confers protection, and if so, for how long. But I don't think we have absolute answers on those things yet.
It is work being done on them.
Yeah, yes, it's a very active area of research, antibodies and other forms of immunity, to try and understand the degree of protection and how long it may last for.
Thank you.
Baroness Healy, have you finished? Can I go on to Mr. Elwood? Yeah, Mr. Elwood, please.
Thank you very much. Indeed, I just want to move on to some questions relating to the vaccines, but in the context of vaccines, it's also to do with organization. And I begin with a very short request, please, whether you agree that we should be stopping to overpromise and need to manage the message far, far better if we are to keep the national resolve in what will be 6 very difficult months ahead of us. Mr. Vallance.
Well, you might be able to tell from the way I've spoken very often that I do think we should not overpromise. I think it's very important that we give a realistic picture of where things are. Do you want me to take that in response to vaccines in particular? Do you want me to answer that question?
Yes, please.
Yeah. So vaccines, if you think about the previous history of vaccines, the average time of making a vaccine from scratch is over 10 years. And it's never been done before in under about 5 years at the very quickest. We're now in an extraordinary situation where there are at least 8 vaccines that are in quite large clinical studies around the world, some of which will start to read out from their late stage, so the end stage clinical studies over the next few months. So we will know, I think, over the next few months whether we have any vaccines that really do protect, and if so, how long they protect for. What we do know is that there are a number of vaccines that create an immune response. That's good news. They do make people get antibodies, and those antibodies, at least some of them, are neutralizing. So that's all good news. But that's a necessary step on vaccine production. It's not the answer. The answer comes from the phase 3 clinical trials, when you find out, do these things actually stop you from getting infected? And if so, how effective are they? And we will know that over the next few months. And at that point, we'll also have some clearer idea on the safety profile of these vaccines, and from there can start looking at what a sensible vaccination strategy could be across the population. And I've been clear right from January, I thought it unlikely to have vaccine for any sort of widespread use in the community before at least spring next year. We may get a few doses before that, but we'll see.
That's very clear indeed, and I think that's what we need to hear, because each week, each day almost, we're seeing different messaging in the newspapers and different commentators, and you're making it very, very clear that we have a number of difficult months ahead in this harsh winter, and we shouldn't expect anything by the spring. It is that clarity of message which is so important if we're to keep the national resolve together, and I'd encourage more number 10 briefings for that exact reason. But the rollout of a vaccine, whatever that might be, and you've gone through some of the difficulties, will be an enormous challenge on the lines of what we saw during the war with munitions or weapon systems as well. And the organization needs to start soonest. I'm aware that the health secretary has requested or not requested, but suggested the use of the armed forces. None of the military, as far as I'm aware, very senior, have been given any formal request of the need to start planning now to organize how the spoke and hub system might work, how the refrigerated systems might work, the database that might be required, how you provide local deliveries, how it ties in with current NHS systems and structures. This is a mammoth task, I'm sure you'd understand. And it does require now organizing with, I think, a lead point, one individual who is logistically an expert rather than necessarily being a health expert, because that's what's required here. Would you agree?
Yes, I think perhaps Clara Swinson from DHSC may want to talk about this, because clearly DHSC will be responsible for vaccination strategy. But I think this is a big logistic challenge. There's no question about that.
please.
Thank you. Yes, good afternoon. So just to take your first point, to agree with Sir Patrick, and I know that the CMO would say the same and has on many occasions. This is a marathon, not a sprint, and this is something where we need to progress work on all kinds of areas, and there isn't a single solution, and testing isn't a single solution, and vaccines isn't a single solution either. But to come to your main point, if and when a vaccine, if it passes the many hurdles that the CSA has talked about, if and when one is available, clearly we need to be and are planning now on the deployment of that. You are quite correct that it is a huge logistical challenge. The Health Secretary has asked NHS England to run that deployment plan. Obviously, we need to work with colleagues right across the whole of the UK. I think there are a number of things that can be planned for, but there are a number of things where the uncertainty about the vaccine and its characteristics means that we're not going to know until, if and until we know which vaccines are being deployed. But the scale of the task is large. I would have thought, I know that there are discussions with MOD. I'll pick up if they haven't gone to a senior enough level about that. I think that's probably around the spec of what we require because of the uncertainties that we've got on the deployment programme. But just, you know, the supply, the logistics, the supply things that we need, the logistics, the data systems and so on are all being worked on. The scale that NHS England, you know, there is a flu vaccine every year that's tens of millions of doses. So there is something of this kind of scale that is done each year. But of course, the time frame, the importance and the timeliness and the interest that will be in this will, I agree, be of a scale that we haven't seen before, and where we're going to need to work with all kinds of bits of the public sector and the military in order to be able to do that.
Good to hear that, but I strongly urge that you lean on the expertise of the military. The MOD is the one department that does Horizon Plan. They train for emergency response. They have the strategic thinkers and the logistic capability to do this. And I, again, underline the fact that we need to start considering this now, because mass vaccination centers, mobile sites, roving teams and so on, even legislation required to allow individuals who are not currently legislated to do so, to give vaccines, needs to go through. Lots to be thought about. I think I've made the point. I would like to just go back, if I may, Chair, very quickly, just to do with the wider issue, which connects with this, that we have policy design and then we have operational delivery. And I don't believe that we've done enough to distinguish between the two. We've not moved to a proper war footing. This is the government not doing, understanding that this isn't like a flooding or indeed a terrorist attack where a COBRA is called, National Security Council is reviewed and what's going on, and you illustrate some answers. This is ongoing, enduring, and it requires faster, simpler decision-making, fewer people at the top. And once the policy is then decided, the strategy is then agreed, it's slid over across to a task force running a situation center that can then implement this. Instead, we have ministers that have no experience in emergency planning, let alone operational delivery, phoning up, chasing PPE, for example, that we saw at the beginning. And as like I said, we have 6 more months of this, and I still don't see a distinction between operational delivery and the policy planning at the very, very top.
That's very interesting, and there are many people who may share your view. I don't think it's probably quite fair to ask any of our witnesses to comment on it, though. It remains clearly on the record. Mr. Graham, I know you wanted to come in on this area.
Chair, thank you very much. I did want to come in briefly, if I might. Sir Patrick, looking at your CV, you've had a huge amount of experience of R&D on new medicines and so on. And so I'm just interested, when I looked at the chart that we were shown on the National Risk Register of Civil Emergencies, there's a chart which shows response to such threats, indicating detection antivirals, vaccines, and personal protective equipment. And under vaccines, it says these will be developed as soon as possible. Once new flu strains are identified, this will take at least 4 to 6 months. The time between when we first identified this pandemic, which I'm assuming is broadly late December, early January of this year, to the timing that you were suggesting, the spring of next year, that's significantly longer. Does that mean that basically, in terms of our strategy, we've underestimated the length of time that it does take to provide vaccines for pandemics?
No, okay, that there's a fundamental difference between a flu vaccine, which you already have, and adapting it as we do every year for a new strain, which is obviously a process which is built into the manufacturing. Everything's in place. It's about making sure you've got the right strain versus inventing a totally new vaccine.
So in terms of the strategic approach to vaccines for a totally new strain, what sort of time span should we actually bear in mind when planning strategy?
Well, prior to what has been achieved with this, I would have said 5 years minimum.
Gosh. So in terms then, if I can turn to, sorry, do go on.
Can I just caveat one thing? There has been a remarkable change in vaccine technology in the past few years. And I think this does mean going forward, this could look quite different. There's been essentially 1 or 2 ways of making vaccines for the past 30 years or more. But in the last 5 years or so, there have been techniques which allow you to go from the sequence of the virus, the genetic sequence of the virus, to a vaccine, an experimental vaccine, in a period of just a few weeks. Then you've got to go through all the testing and manufacturing, but there is now a way, and these first wave of vaccines, so-called messenger RNA vaccines, is one of them, are going to be first out of the block for COVID, I think. And so we'll see then whether they work. And if they do, that could radically change how one thinks about vaccinology, and that could accelerate that period. But up until now, that hasn't been possible.
That's very helpful. So you're effectively saying that strategically, the current planning time would be 5 years to develop a vaccine, but that's now coming down quite sharply, but it's still looking like around 18 months. Is that the...
It could, if these messenger RNA vaccines work, and I'm just picking on them as an example, it could even be faster than that in the event of an outbreak of a new disease. They do provide remarkable speed, potentially.
Right. And bearing that in mind, can I turn, Chair, to Clara Swinson? Ms. Swinson, I mean, bearing in mind Sir Patrick's comments on that, it does look to a lot of us as if the way the government has to respond to a pandemic challenge like this is to really bear in mind, above all, what is our capacity for dealing with it if we have people who need to go to hospital and need to go on to ventilators. That does seem to be the driving force in the containment strategy. So do you think that strategically we should be trying to analyze how long it is realistically going to take to provide a vaccine solution for a new strain in the way that Sir Patrick's suggesting, because that then enables you to plan effectively for how long you need to protect the NHS, quote unquote, and for how long you're going to need additional bed capacity, more ventilators, and so on.
Okay, if I could ask you to be a little bit brief in your reply, because we do want to move on to another area.
Of course, thank you. So on vaccines, we talked about the reasonable worst case scenario earlier. This is one area where ministers have asked us to prepare for the reasonable best case scenario. There are many challenges on the time frame and the history, as Sir Patrick has set out, but that is why led through BAYS and the Vaccines Task Force, we're looking at how we can be ready as early as that can come on. I think if I just take the last point of the question, no, I don't think, and I think CMO and the CSA have said similar things in the past. I don't think it is a single vaccine that will bring this pandemic to an end. It's work across vaccines, it's improvements in treatment, it's novel treatments, it's prevention, it's testing, and it is probably keeping some of the measures, hopefully, and I'm sure not on the extreme side, but the way that we have changed, you know, everything from hygiene, COVID secure premises and so on, we're going to need a balance.
I understand. I understand your point on this one. The point, Chair, is just gently trying to get at was strategically and in terms of planning for any future events. Isn't this the crucial bit of information that we really need? Because once you know roughly how long it's going to take to develop a vaccine solution, you can then say, right, this is the period of time that we need to plan in order to have the beds, the ventilators and the NHS people in place for until we've got that mass solution. Isn't that, I mean, I'm just asking the question, isn't that one of the most crucial questions we need to know in advance?
Yes, and on flu vaccine, we had an idea about how long that would be. On this vaccine and the different technologies that Sir Patrick talked about, there were many more uncertainties.
Thank you so much.
Baroness Neville-Jones, please. You're muted.
Yes. I wonder if we could move on to the question of testing and the lessons that we've learned from that. Here, the lay public hears about exercise sickness that took place. And what I'd be interested to know is how the department and PHE subsequently took on board the results of that exercise. Do you think, in fact, that you took on board all the elements that should have been the case? And how has, as a result, behaviour and what you've done changed as a result of that exercise? I think probably that's for Ms. Swinson, primarily, but others may wish to comment too.
Of course, thank you. So yes, there's an extensive exercising and testing programme. And as well as that, of course, there have been lots of incidents, whether that's terrorism, severe infectious diseases that were contained, a small number of cases and so on that we learn from. Of course, you know, how effective that, it's a very good baseline to have. We learn from each of those exercises that we've done, and PHE or I can talk a bit more about that. How effective that baseline is, the extent of the exercising, how far the lessons were learned from and put into place, and we're ready to go, is obviously going to be a matter for further reflection at a later point after we're through this pandemic. I don't.
Does anyone else comment? One thing that worries me about that exercise is, that it only dealt with a couple of the stages of the pandemic, and it didn't deal with some of the ones that have actually proved most testing. In addition to which, there were the reports. The report came out, which made a series of recommendations. As far as I can tell, they weren't implemented. So one does ask the question: what is the value of? Are we kidding ourselves in holding an exercise of that kind when it doesn't actually deal with all of the stages that you need to go through and which I've identified? And secondly, the outcomes and the recommendations are not then followed through. It isn't a model, it seems to me, that's actually working at the moment.
So on the exercising, sickness itself, as you say, it ran as an exercise. You're quite right. You've got to choose some elements for that exercise. There were tabletop exercises and a range of other things, but whether to what extent everything was tested, and the balance between what you choose between these kind of biological risks, preparing, for example, for terrorism attacks and so on. Many of the ways that agencies have to work together are similar, whatever the incident is, but others are specific. So there's a balance to be struck there. I'm not sure what report you're referring to on the recommendations that you think haven't been implemented. In terms of the sickness report and the recommendations.
I can tell you, mean, there were recommendations about the procurement of things like PPE. The whole series of practical things which were recommended, which, as far as I can tell, weren't followed through. I mean, I get the impression that, I mean, I understand all the difficulties, but I hope you're not telling us that you regard that outcome as a successful model of how testing should actually give you a good basis for then following through on the recommendations and being of real value. It seems to me, on the whole, what happened was it gave false comfort. But a lot of things that should have been done weren't followed up.
So not at all am I saying that that whole exercising program is a perfect program. I'm just saying that you need to choose which elements.
Yes,
and PHE design not just sickness, but a range of tests that John might want to talk more about. In terms of the recommendations,
Professor Simpson, next.
Go ahead. Sorry, Chair.
Professor Simpson.
Yes, as Klaus Winston's saying, PHE has for many years run and designed exercise and predecessor organisations exercises for the health sector primarily, but for some exercises such as pandemic flu exercises for a much wider set of stakeholders. As has been said, these are based on what the national risk assessments and what NHS England and DHSC regard and ourselves regard as the highest and most pertinent threats at the time, and this is reviewed regularly yearly. With the pandemic influenza exercise, and I believe the report is being published this week, what one has to do is to look at what are the parameters in which you are going to test. And we did test a great number of parameters. One thing that is particularly difficult in general with exercising is long-term stress testing, because you can't really take people out of their job for a month and have them part of an exercise. So there isn't always going to be an element of artificiality about that. However, we do try and exercise designers worldwide do try and take this in. On the exercise itself, sort of 950 people did take part in it. So it was a large scale exercise to look at how a pandemic influenza, and I stress that pandemic might play out, particularly on health and on the health sector. So I'll finish there, Chair.
Lord Harris. Oh, sorry, Lady Neville Jones.
I just want to say, do you regard the outcome, therefore, of that exercise as being, would you judge it as successful and fulfilling its purpose?
The purpose of the exercise, from as we were approached, was to run a pandemic influenza scenario which had input from many stakeholders across government. The exercise was run, and the report was written, and the recommendations were made. And there have been previous exercises also about pandemic influenza, and therefore once the exercise is done, then from that as an exercise, yes, I think it was successful.
So the fact that the recommendations weren't followed up, is that, you think it's successful but not your responsibility, or it didn't matter?
I think saying they weren't followed up is rather strong, and when the report is published, I think that will be apparent. Some of the recommendations were for PHE, some of them were for other agencies, and it's for all the agencies involved and all the departments involved to take away their the recommendations for their activity and to look at how they might address those amongst in the future.
I don't want to take the parallel too far, but I am reminded of the observation that the operation was successful, but the patient died. Lord Harris.
Yeah, I'm tempted to follow up and say it was obviously so successful that we've been waiting 4 years or whatever it is for the report to be published. But I want to move back briefly to local resilience forums. I think we were told earlier that they had received a reasonable worst case scenario on a pandemic flu, but I'd like to focus on the workings with local resilience forums, both in terms of the risk assessments and the preparations in advance of COVID-19, but perhaps even more importantly, during the pandemic itself. How well did that work? And perhaps we could start with Ms. Swinson.
Thanks. So, I mean, local resilience forums that bring together, all the agencies in a local area, they're varied, but in terms of, the response in local areas and the work with the NHS, and social care, which is obviously our responsibility from our department. I think that those two things, in terms of the resilience of those two sectors, they often differ. There are a range of other things that the Cabinet Office and MHCLG and other departments are requiring local authorities to do. Obviously, they're under a lot of pressure. So I think it comes back to this question that we were discussing earlier about the balance between national and local.
Okay, but could I ask more generally, and not just to you, but to the others, do you think, having experienced and gone through the COVID process or going through it, does this show any need for particular changes to local resilience forums, to the system as a whole? Are there lessons which you can already draw from the way things have worked? And I'd be interested in both your comments, Clara Swinson, but also from the other two witnesses.
So definitely the scale of contact tracing and testing we've talked about, and the role of the local director of public health is an incredibly important one. Statutory responsibilities, and they need to be supported with the resources to do their job in a local area. I think that just going back to the conversation we were having, certain things are tested. We are undoubtedly in a better position. I believe that we've worked on all of the recommendations from the Sickness Report, whether that's national or local, but clearly how effective beyond that, and whether other things should have been tested, including at local level, people have got reasonable questions about that.
I don't know whether either Professor Simpson or Sir Patrick want to add anything to that.
Yes, I think the point I made earlier about the way local resources and being able to increase the amount of activity and resources that there are at local levels to do particularly test and trace, and to do contact tracing in future, and how that can be expanded.
I'll make one comment, if I may, which is not on local resilience forum, which is really not my area, but I think there's one thing that is relevant to not only this emergency, but to other things on the National Risk Register as well, which are data ownership, data flows and analytics, and being very clear where all those things lie in any risk is crucially important. And I think it's a very key lesson to get that right across all of the risks.
That could take us off in all sorts of interesting byways, which I will resist. But could I just ask one final question very quickly? Do you think there are any lessons from how the different devolved administrations have handled the crisis? And I don't know who wants to go first.
Well, I think from a science and medical point of view, we've been very joined up, actually, and that's worked really well. And I know the Chief Medical Officer would echo that. He meets with the devolved CMOs very, very frequently. They've been completely joined up, and we've had all of the devolves on Sage. And although they've got their own science advice mechanisms as well, it all feeds from what's going on across the science world. So I think it's been pretty joined up from that perspective. I won't comment on the operational policy aspects. Others may wish to.
Swinson.
Thank you. You know, in terms of my role, I'm either responsible for things that are UK-wide or devolved, but I'll take your question. Clearly, there are areas where the 4 nations have taken different paths, and one of the things that we'll be able to do is compare and contrast those choices. One of the lessons I would definitely take from that is that, you know, politicians take different decisions, and the balance between them. We know, though, it is, and I know some of your previous witnesses were talking about this, it's very hard for people who are living near a border, particularly when the guidance is different. Of course, it's a consequence of the devolved system we've got, but the communications in each administration is definitely something that we know is difficult for people because of those differences. Thank you.
Professor Simpson.
Yeah, from the public health response aspects, we've had very close working relationships with our colleagues in public health departments and agencies in the devolved administrations. We have we've had meetings every day throughout the pandemic, starting in January, where we've discussed things jointly. So that we'll be learning lessons and looking to increase our ability to coordinate our activity in the future.
Lord Powell. Lord Powell.
Sorry, let me bring it together just one question about lessons which can be learned both from home and abroad. I mean, the 3 of you have lived with this for 9 months or more now, and you've done heroically. When you look back over it, are there 1 or 2 points you think, from your own personal experience, if we'd done it this way, it might have worked out better? Or when you look at 1 or 2 other countries, are there points you say maybe they got it more right than we did? I'm not asking for criticism of the government or anything like that. It's government's quite hard enough without vicarious criticism. But are there just 1 or 2 points you would draw to our attention as to how things objectively could have been done differently and might have had a better result if we had followed the example of other countries, or just lessons we derived ourselves?
Sir Patrick. Sir Patrick?
Yes, I mentioned one, which is on data, understanding what data, and we were flying blind for quite a long time because we didn't have data, and therefore you can't make decisions in the absence of data. I think the second observation would be, in all of these public health areas, you need significant spare capacity, you need surge capacity. You can't run at a minimum. The third I'd say is that we haven't got a significant private sector testing capacity in this country, and that was quite important, certainly in some areas like Germany. And I think the general lessons that have become clear is that when you see a disease like this moving, you've got to move fast, you've got to go in quite hard with the measures you take, and you've probably got to go a bit broader in the geography than you.
Thank you.
Ms. Swinson.
Thank you. I agree with those points. I would just widen the one that Patrick has just made. You know, a crisis, you know, a pandemic like this, it shows up where the countries are, where our strengths are and where our weaknesses are. So on our manufacturing capacity, there's both diagnostics, there was our reliance on PPE, where there was no UK manufacturing really. It shows up our strengths in other areas. And domestic ventilators, there wasn't industry, so it shows up those. The only other thing I would say is clearly the communications and the behavioural aspects of these things. You know, you can plan really well, you can get great policies, you can even get great operations, but really thinking about you know, why people act as they do, what the best messages are in order to increase compliance, and the balance between enforcement and support. You know, those are hard things to get right, and I think there are lessons on that that I would draw. Thank you.
And Professor Simpson.
I think the ability to increase and have spare or trained capacity for expert and operational roles, and the ability to increase numbers. The second thing is that this was a new virus which came from an unexpected source. So I think one thing for the future is increasingly to look to the unexpected, and try not to fight the old military adage of trying to fight the last battle. Is going to be important. That we need to look at where things may come from, and also have systems that can respond to that.
Thank you. Very clear, useful answers. Thank you.
Yes, there were. And I just make one observation, which is that basically it seems to me that you're telling us that we've been running on far too tight a margin in too many areas for far too long, which when it comes to our basic remit is something that would be of concern to us when we look at other issues which are in the risk register as tier 1 risks. Maybe that's something for us to think about more widely. Can I thank all of you very much indeed, particularly as I said at the outset, for coming at a time when you're under so much pressure elsewhere. We really do appreciate it. Thank you very much indeed. I'm going to draw the committee to a close. Order, order.
Thank you.